Hello everybody. At the outset, I want to thank Dr. Uma for inviting me to participate in this workshop on rejection. I'm going to be talking to you about the morphological aspects of both T-cell mediated rejection and humoral rejection. I'll begin first with T-cell mediated rejection. Before I go into the morphology, the biopsy should have 7 glomeruli with at least 1 artery, but it would be nicer to have 10 glomeruli and 2 arteries to give an adequate BAF grading in the diagnosis. Most often 7 slides are examined and they are divided between the H&E staining, PAS and trichrome stains. In this photo, you will be able to see that we have a large cluster of lymphocytes present in the center, almost completely overwhelming the tubules. At the periphery, there are a few singly scattered cells and smaller clusters. If this inflammatory cell component occupies less than 25% of the biopsy, we can only suggest a diagnosis of borderline or suspicious T-cell mediated rejection, which has 2 components to it: the inflammatory cells present in the interstitium and the cells encroaching into the tubular lumen. Even before we look at the inflammatory infiltrate, which we are seeing in this slide, you will notice that the biopsy has significant interstitial edema, which is seen in almost all rejection slides, both T-cell and humoral. The lymphocytes are admixed with eosinophils and macrophages, and when they occupy more than 25% of the interstitium, devoid of changes of chronicity, they get labeled as definitive T-cell mediated rejection. If the inflammatory component occupies more than 25 or 50%, they get graded accordingly. And as I was telling you, that the cells then start involving the lumen of the tubules. Here is a PAS section showing the peripherally present basement membrane of the tubules. It then becomes easy to see that these small round cells or the lymphocytes are encroaching upon the epithelial cells and in the lumen, and then it is very easy to count their numbers. Depending upon how many cells you have in the tubular lumen, they are graded from less than 4 as 1 to greater than 10 as 3, as you can see in this slide. And here you can see that the lymphocytes are admixed with eosinophils. A CD3 marker, which is a marker for all T lymphocytes, shows in both these areas that all the cells are strongly positive with CD3, suggesting that the lymphocytes are all T-cell lymphocytes. Sometimes the T cells are associated with plasma cells, which mark as CD138, and B lymphocytes, which mark with CD20. when the T lymphocytes are associated with plasma cells and B lymphocytes, then it has been noticed that the outcome of these transplants is poorer, as we too noticed in a small study that we conducted at our center. Along with the interstitial involvement and the tubules, the glomeruli may also show an increased number of lymphocytes in the lumen, and then they are called as glomerulitis. Here is an electron microscopy view to show you that all the cells in the tubular lumen are lymphocytes. The hallmark of transplant affecting the glomerulus is seen as changes in the basement membrane. You can see the external epithelial end and the endothelial cell nucleus in the at one end of the slide. The basement membrane is markedly increased in thickness, and there is significant vacuolization alternating with granular material. This change is noted in both T-cell mediated rejection and humoral rejection, and can be the earliest manifestation of rejection. The blood vessels also get affected, and you can see in this slide that there are a large number of lymphocytes which are present just below the endothelial cell lining of the vessel. Even one lymphocyte is adequate for us to label this condition as endothelitis. And you will see that all the cells have marked with CD3, suggesting that these lymphocytes are T lymphocytes. In lesions which are a little more severe, the lymphocytes may be associated with early fibrin-like material, and in the more severe cases, along with the lymphocytes, you can see fibrin material involving the entire wall of the vessel. Moving on to the chronic changes, when the biopsy has significant lymphocytic infiltrate in some regions and in other areas shows you interstitial fibrosis with small tubules of tubular atrophy, then this is labeled as an active component with a chronic component, suggesting a diagnosis of chronic active T-cell mediated rejection. So just to summarize that along with the changes of chronicity, the identical changes that you see in active T-cell mediated rejection may be seen pari passu in different regions of the biopsy. Sometimes the vessel is also affected. You can see that this is an elastic stain because it has marked the internal elastic lamina. Lying on the inner side, just below the endothelial cell, are a few foam cells and increase in the reticulin fibers, suggesting changes of chronicity. Now let us move on to the antibody mediated rejection. As I mentioned earlier, the first change that we will see in biopsies of rejection is severe interstitial edema, where the tubules are separated away from one another with increase in interstitium, which is a feature we never see in uninvolved tissue. Along with interstitial edema, in this slide you can see that there is a region where we don't see any tubules at all, where there is complete breakdown of the basement membranes. This suggests that there is massive tubular injury along with hemorrhages in the interstitium. In some cases, you may find neutrophils in the tubular lumen, and in transplant biopsies, the moment you see neutrophils, the warning bells must start ringing. The neutrophils have to be searched mainly outside and involving the lumen of these peritubular capillaries, which are dilated in most areas, and in normal biopsies these cannot even be seen routinely. Other than if you specifically search for them, you may find them in some regions. So not only do the neutrophils encircle the peritubular capillaries, but even encroach into the lumen, which is the hallmark finding of an active humoral rejection. Sometimes the neutrophils may be accompanied with lymphocytes and histiocytes. The neighboring tubules contain hemorrhagic material and show loss of the nuclei, suggesting tubular injury. Along with the tubules and the peritubular capillaries, the glomeruli also bear a significant brunt in active humoral rejection. The earliest manifestations is increased number of the neutrophils within the capillary lumen. Few glomeruli may show the presence of the fibrin thrombi, which are seen even better on the PAS sections over here. And sometimes they are very well seen in markedly dilated capillary loops. In this neighboring capillary loop, you will see that it has got completely dilated and distorted because the central mesangium is not seen. This is called as mesangiolysis. This is also seen in this glomerulus, but the area which is empty in this is filled with fibrin, like it is seen in this PAS section. Now, it is very important to remember that all these changes will be seen in a case of thrombotic microangiopathy. Hence, a simple histology examination is not adequate for a diagnosis of active humoral rejection, and I shall come to that in the next few slides. Along with the glomeruli, the vessels also show changes. Here is a medium-sized vessel, and the cells which are projecting into the lumen are markedly swollen endothelial cells. In a normal vessel, the endothelial cell is barely visible as it is extremely flat. In a few regions, the vessels may also show tiny areas of necrosis with fibrin material and almost no patent lumen. Some other glomeruli will show you the lymphocytes present below the endothelial cells, forming endothelitis lesions. Hence, it is important to remember that the vascular component may be seen in both T-cell mediated rejection and humoral rejection. Sometimes, if the disease is extremely severe, the entire biopsy may show you an infarct. As you can see, the tubules over here present themselves with only a ghost-like appearance, The glomeruli contain hemorrhagic material and fibrin, and the vessels also contain red blood cells. The electron microscopy findings are identical to those that I showed you in the T-cell mediated rejection. You can see this is the inner aspect of the capillary loop because it contains the red blood cell. You can see the outer epithelial foot processes and the markedly thick basement membrane with vacuolization and granular material affecting the entire wall or the basement membrane of the capillary. Identical changes are seen in patients of thrombotic microangiopathy. Along with that, sometimes you can also see that the capillary loop has got completely obliterated with a very tiny lumen by this markedly swollen endothelial cell. In a few cases, the glomeruli may get packed with the lymphocytes like we saw in the patient of T-cell mediated rejection, suggesting that the patient has a glomerulitis lesion involving few of the glomeruli. At electron microscopy, you can see the thick basement membrane showing central vacuolization and lumen packed with lymphocytes, fibrin-like material, and a swollen endothelial cell. Histology is one aspect of the humoral rejection, and all the histological features I have already enumerated. Along with that, we have to show the presence of C4d positive in the capillaries which are present between the tubules or the peritubular capillaries. Both these sections have been stained by immunohistochemistry or immunoperoxidase staining. Immunofluorescence staining also shows you the deposits in the peritubular capillaries. So, if the immunofluorescence staining is negative, it is important for you to do the IHC on the other tissue because the two cores are different, and very often the C4d staining starts primarily in the capillaries closer to the medullary regions. Along with the C4d and the histological findings, the DSA levels have to be estimated, wherein then if they are positive, we can give a specific diagnosis of active humoral rejection. Sometimes the C4d staining is negative. In these cases, it is the combination of the histology findings which must show you all the features that I have mentioned, starting with interstitial edema, tubular injury, if present glomerular and vascular changes, but peritubular capillaries surrounded by neutrophils appearing dilated are mandatory. The chronic changes that you see in antibody-mediated rejection mainly involve, of course, the interstitium and tubules, which show you the chronic changes of interstitial fibrosis and tubular atrophy. But the glomeruli show a specific appearance wherein they mimic the pattern of a membranoproliferative disease. So you can see the lobules with spaces occurring between the capillary loops, thick basement membranes, and sometimes a mild increase in the number of mesangial cells. Of all these findings, what is most important to see that the basement membrane thickening has happened due to the double contouring. which you can see on the silver stain. You can see that the basement membrane has split into two, which is actually the change that you see even better at electron microscopy, which I showed you both for the T and the B cell, humoral rejection. And you can see it in the silver as well as the Mason stain slide. Along with this, where you may have a MPGN pattern, in some scenarios, the patient may have a FSGS lesion. Both can be associated with chronic humoral rejection. However, to be 100% certain that it is due to chronic humoral rejection, a C4D staining of the glomerular capillary loops is essential, which confirms the primary chronic humoral rejection phenomenon, because transplant glomerulopathy can also be seen in patients having chronic T-cell mediated rejection. If in addition to these chronic changes, we also have features of capillaritis, that is the neutrophils in the peritubular capillaries or in the glomeruli, changes of TMA or vasculitis or tubular injury, and we have the peritubular capillaries showing C4D, then we give a diagnosis of active on chronic antibody mediated rejection. The vessels also show the identical changes that we see in the active component, but along with few features of chronicity. This vessel, you can see, is completely overwhelmed by the infiltrate of lymphocytes, and another vessel in the same biopsy shows changes of chronicity with very occasional lymphocytes below the endothelial cells. So, fibrin-like material with endothelial swelling along with intimal fibrosis and fewer inflammatory cells in other vessels. At electron microscopy, as I've been showing you, very wide basement membranes, but the basement membranes have split into layers, which you can see better in this photograph over here. And if you see the peritubular capillaries, you can see that you can actually count the layers as 1, 2, 3, 4, 5 and multiple layers over here. So once you see the peritubular capillary splitting into its various layers, if the splitting is more than 3 in number, that suggests that early changes of chronicity have begun, and when they go beyond 7, then the diagnosis is final of the chronic changes. These are the first changes that come in patients having chronic rejection phenomenon, and hence it has now become almost mandatory to do the electron microscopy so that we can find out if the patients have already started developing chronic changes and then modify the treatment accordingly. I have just quickly summarized all the morphological changes for you of both active and chronic T-cell mediated rejection along with active and chronic humoral rejection. Thank you so much for inviting me to participate in this workshop.